surgery, but it can also arise without spontaneous also arise spontaneously without any inciting event. So it is primarily characterized by the constellation of sensory, motor, autonomic, and also trophic abnormalities. So as we all know, there are two types. The type 1, initially traditionally it was known as causalgia. It is diagnosed in the absence of a specific nerve injury. In type 2, it is traditionally known as reflex sympathetic dystrophy. It is diagnosed in the presence of a specific nerve injury. So what is the objective for developing a new guidelines? It is to develop updated evidence-based diagnostic guidance for chronic complex regional pain syndrome, and also to introduce the time-based diagnostic criteria. How many months, till what months we can call it as acute, and after how many months should we call it as chronic, and improve the diagnostic accuracy and clinical outcomes, and also address the limitations of the Budapest criteria, which is traditionally used for the diagnosis of the complex regional pain syndrome. So the methods, as we all know, they used an expert multidisciplinary panel under the American Society of Interventional Pain Physicians, and comprehensive literature review was done, and structured consensus was arrived. So what is the difference between acute and chronic CRPS? The main pathophysiology in acute phase is because of the vasodilatation, it is an inflammatory phase, and the extremities are warm and swollen. In the chronic phase, it is mainly because of the decreased perfusion, which leads to dystrophic, cool, and cyanotic limb. And in chronic CRPS, it shows irreversible tissue atrophy, contractures, and also secondary pain because of these changes. So what is the Budapest criteria? As we all know, so it has four major points. So the first point is continuing pain disproportionate to any inciting event. And the second criteria is there should be at least one reported symptom in each of the following four categories, which is sensory, motor, pseudomotor, and trophic. In sensory, either there should be hyperesthesia or allodynia. Vasomotor, there is temperature asymmetry and or skin color changes. So in pseudomotor or edema based symptoms, swelling, sweating asymmetry should be there between the two limbs. And in motor or trophic changes, there is decreased range of motion, motor motor dysfunction, under or trophic changes like loss of hair or changes in the nails and the skin. So, and uh, one observable sign should be present in two or more of the following four categories. In the sensory, either there should be hyperalgesia or allodynia. So hyperalgesia is like increased pain to the, so the amount of pain which is caused by something is very high. Allodynia is having pain to a non-nauseous stimuli like light touch, light temperature, deep pressure, and joint movement. These usually doesn't cause pain, but if there is increased pain to this, then it contributes to the sensory symptoms. In vasomotor, there is temperature asymmetry of greater than 1 degree Celsius between the extremities, or skin color changes or asymmetry. In pseudomotor symptoms, there should be edema, sweating changes, or sweating asymmetry. In motor or trophic changes, there is reduced range of motion. Motor dysfunction like weakness, tremor, dystonia can be present. Under or trophic changes like changes in the skin, hair, and nail will be present. And the fourth criteria is it is a diagnosis of exclusion. No other diagnosis better explains the observed signs and reported symptoms. So Budapest criteria has a higher sensitivity of 99% and moderate specificity of about 68%. But the limitations of the Budapest criteria, it is primarily validated for the acute complex regional pain syndrome, and it fails to capture the chronic stage features like atrophy, dystonia, and also it lacks duration based differentiation for acute and chronic CRPS, and it is subjective, lacks standardized scoring or biomarkers for diagnosing, for differentiating between acute or chronic CRPS. So then the guidelines which were given, the diagnostic framework for the chronic CRPS, it again has four things. So there is a general criteria, which means the Budapest criteria should be fulfilled for greater than or equal to 12 months, and CRPS will remain as a diagnosis of exclusion. And the history based criteria will also be there, in which at least greater than equal to 3 of the 5 historical features should be present. And the physical examination based criteria, which includes asymmetry, sensory and musculoskeletal changes, and the optional diagnostic criteria are used for as a supportive methods to establish chronic CRPS. So the general criteria, so Budapest criteria for at least 12 months. So 12 months is the cutoff beyond which we can call it as chronic CRPS, and it remains as a diagnosis of exclusion, and it must be differentiated from primary or secondary nociplastic pain conditions causing generalized pain. So on the history-based criteria, either 3 out of the 5, the 5 things are sensory, vasomotor, pseudomotor, motor, and trophic, and motor trophic, and contralateral overutilization. As we have all seen the sensory, vasomotor, pseudomotor, and motor changes. So the one more extra thing is contralateral overutilization. There is increased use of the unaffected limb because the patient is having pain in the limb in which he is suffering from CRPS. So due to dysfunction, there is dysfunction of the unused limb. So in the physical examination criteria, at least 2 of the 3 must be present. So the 3 things are avoidance of usage of the affected limb with contralateral dominance or overuse. And there is evidence of allodynia, hyperesthesia, and/or hyperpathia or reduced tactile acuity. Example, decreased 2-point discrimination in the affected limb compared to the unaffected side. So and asymmetric limb girth accounting for factors such as occupation, activity level, or hand dominance. For example, in suppose some persons might have right hand dominance. So even if the if the left hand is affected, obviously, even if the left hand is unaffected, the right hand must be overused because of the natural activity. So these things should be accounted while measuring the asymmetric limb girth. So under superficial or trophic changes, at least 2 of the 3 must be present. So the trophic changes include skin, nail, and hair changes. So the vasomotor findings, so there is visible temperature change of greater than 1 degree Celsius between the limbs or skin color changes. And the pseudomotor changes include the asymmetric edema or diaphoresis, which means like the sweating between the 2 limbs is different. So the musculoskeletal trophic changes include all the 3 criteria must be present. There should be decreased range of motion. This is mainly for the chronic CRPS. There should be decreased range of motion, contractures or fixed postures, motor dysfunction including weakness, tremor or dystonia, musculoskeletal changes including atrophy, changes in limb girth or joint abnormalities. Example, frozen shoulder. And the fourth is the diagnostic criteria, which is an optional supportive criteria. These tests are not required, but it may support the diagnosis when the first 3 criteria are met. So which includes reduced intraepidermal nerve fiber density on punch biopsy. So this is an invasive procedure. Bone demineralization in the affected limb. So either via X-ray, CT scan or bone density testing, and positive response to sympathetic block indicating sympathetically maintained pain. So here is the tabular column which shows the difference between the acute and the chronic CRPS. In acute CRPS, the range of motion is not affected, but in chronic CRPS, 20% loss compared to the other limb. In limb girth, acute CRPS, it is not affected, but it is decreased because of the muscle atrophy and the contractions. Grip strength is also affected approximately to about 20 to 50% compared to the other limb. Sweating, there is increased sweat production during the thermoregulative sweat test in acute CRPS, but in chronic CRPS, it is although it is increased, but it is attenuated compared to the acute CRPS. And in quantitative pseudomotor axon reflex test, it is increased sweat production is there in acute CRPS, but in chronic CRPS, there is no difference in the both the limbs. And with regards to the hyper and hypoalgesic changes, warm and cold hyperalgesia, warm and cold hypoaesthesia, and paradoxical heat sensation, all these things are present in the acute CRPS, while in chronic CRPS, it is less warm and cold. Hyperalgesia is always present, plus warm and cold hypoaesthesia is more severe when compared to the chronic contralateral limb. So the skin temperature changes is roughly about plus 60 degrees Celsius to 1 degree Celsius in acute CRPS because it is majorly warmer, but in chronic CRPS it is much cooler. The sensitivity to the thermal stimuli, it is more sensitive bilaterally in the chronic CRPS. So the objective diagnostic markers include the quantitative sensory testing, which differentiates between the hyperalgesia and hypoesthesia between the two extremities, and thermoregulatory stress test and quantitative pseudomotor axon reflex test. All these things we have seen how it is different in acute and chronic CRPS. And infrared thermography, diffuse reflector spectroscopy, these can be used for looking at the microcirculation, and force transducers for grip strength and limb girth measurement and range of movement analysis. All these things can be done to diagnose the to support the diagnostic criteria for the chronic CRPS. So the key biomarkers, the immune, neurogenic, and neuroinflammatory changes which is happening in the acute and the chronic CRPS are: there is increased TNF alpha, IL-6, and tryptase in the blister fluid in acute CRPS, and there is increased mast cell activity in the acute phase. So there is increased CD14 and CD16 and monocytes and T lymphocyte activity in acute CRPS. The substance P and the calcitonin gene-related peptides, these are majorly increased in the chronic CRPS. So MMP2 associated with trophic changes in the chronic, this is seen in the chronic CRPS. So the advanced diagnostic modalities include functional MRI, skin biopsy, bone scans, and autonomic function testing, and serum biomarkers for the differentiation. But these things are limited because of their availability and also affordability. So in treatment overview, it is always, as we have always known, it is a multimodal management, and it has four major pillars. One is the physical rehabilitation, the pharmacotherapy, the interventional pain management, and the psychological or the behavioral changes which they should bring. So now we will see about the pharmacological things. So first line of drugs which is used for the treatment of CRPS is NSAIDs, but it is cautioned or contraindicated in the elderly, as we know, because of its side effects. Although CRPS has shown an inflammatory pathology, the NSAIDs have not demonstrated consistent clinical effectiveness in reducing the pain in CRPS patient. So the second drug which are we going to see about is ketamine. It has a variable dose ranging from 0.15 mg per kg to 7 milligram per kilogram. So it is beneficial for patients who do not respond to more conservative measures, but the side effects like psychomimetic and dissociative side effects are always there. Especially in elderly patient, it can lead to cognitive disturbances, impaired balance, and increased risk of falls. So other NMDA antagonists include dextromethorphan and memantine. So alpha receptor modulators, the alpha 1 blockers include terazosin, phenoxybenzamine, and the alpha 2 agonists like clonidine and dexmedetomidine. These can be used for the treatment of the CRPS. They reduce the sympathetic stimulation and thereby it alleviates the pain. So other drugs like phenoxybenzamine, it has additional benefits like suppression of the macrophage activity through cytokine modulation and also inhibition of the calmodulin, as we have seen in the pathogenesis. So these macrophage activity is also involved in the pathophysiology of the CRPS. So bisphosphonates, its mechanism, how it actually benefits, reduces the pain in CRPS remains unclear, but it has been well tolerated and it reduces the pain, and also it has an additional benefit of preventing the bone degradation which happens in the chronic CRPS. The drugs include clodonate and pamidonate. So the other drugs includes anticonvulsants, antidepressants, and neuropathic medications. They lack well-designed double-blinded prospective studies supporting their efficacy. The commonly used drugs include gabapentin, amitriptyline, carbamazepine. So the effectiveness is limited and it is very inconsistent. Though other drugs in this categories include doxepin, duloxetine, venlafaxine, and milnacipran. So the immunotherapy treatments, so since the inflammatory pathologies and immune mediated pathologies are involved, these majorly act by interrupting the pro-inflammatory process which is happening in the CRPS. So TNF alpha inhibitors, immunoglobulins, IL-1 antagonists, glucocorticoids, all these has been used. They exert. So apart from these agents, immunotherapy agents, anti-inflammatory agents like DMSO 50% cream, N-acetylcysteine, mannitol, vitamin C has also explored for their additional properties like free radical scavenging properties. So TNF-alpha inhibitors like etanercept, thalidomide, infliximab, these are majorly used for the treatment of rheumatoid arthritis. They have their anti-inflammatory properties, but the optimal duration for which it can be used in CRPS is still unexplored. Symptomatic inflammation is always reduced, and whenever it is used, the patient should always be screened for latent TB before starting the therapy. So thalidomide, so the mechanism of action, it upregulates the interleukin 10. So hence, which is majorly involved, which is one of the major chemical which is involved in the anti-nociception, which is expressed in the spinal cord. So the side effects include, as we all know, teratogenicity, and apart from that, the other side effects include constipation, hypothyroidism, ACTH stimulation, somnolence, sedation, and deep vein thrombosis. So immunoglobulins, the mechanism of action is ability to neutralize the pro-inflammatory antibodies. It can be used either IM or IV. It contains both IgA and IgG antibodies. So the side effects include flu-like symptoms, dermatological reactions, arrhythmias, hypotension, transfusion related acute lung injury. So IL-1 modulation, interleukin 1, it is a chemical which is majorly involved in neuronal stimulation. So when we use IL-1 receptor antagonist, it either by targeting the direct antibodies or combination of therapies or recombinant cytokine biological agents, it can act as a potential therapeutic strategy. But the limitation is when if we have to develop such kind of drug, they have a large molecular weight. Hence, the formulation of the drug and the mode of delivery still remains a challenge. Glucocorticoids, the mechanism of action, it targets the inflammatory pathways. It exerts immunomodulatory effects through inhibition of the interleukin 2 and NF beta signaling and suppression of the mast cell degranulation, reduction in the release of immune cells from lymphoid tissues. The side effects, as we all know, when we are using for a long time, it has dose and time dependent metabolic and various other side effects. And tapering is also very difficult when we are using for a long time. So the key takeaways, the 2025 American Society of Interventional Pain Physician Guidelines for Chronic CRPS, it is the first structured criteria which exactly states greater than 12 months it is diagnosed as chronic CRPS. And the focus on the chronic phase, especially in the musculoskeletal and neurogenic changes. It combines the clinical history, physical findings, and optional objective tests. It also encourages the research into biomarkers and personalized therapy. Thank you.
Thank you, Dr. Aravind. So that was our first paper regarding the diagnostic criteria for CRPS and the treatment. And we'll go to the second paper, and then in the end, we'll discuss both. Dr. Amol, can you share your presentation?
Yeah, just a minute. Are my slides visible, ma'am?
Yes.
Okay. Good morning, everyone. I am Dr. Amol Bansal, Consultant Pain Medicine, NIVAAN Pain Clinic, Atlanta Hospital, and JEEVAN MAALA Hospital, New Delhi. And I'm going to present a brief review of complex regional pain syndrome and current management, and it is insight from 2024 Annal of Medicine Review articles. So come to the introduction to the CRPS, as it was already covered by Dr. Aravind. It's a rare debilitating chronic pain condition, basically affect distal extremities. And their type and classification, I'm just taking it briefly as it was already covered. So it's two types, type 1, type 2, at presence of nerve injury and absence of nerve injury, as well as on clinical types, warm type and cold type. And their pathophysiology is multifactorial. Mainly inflammatory mediators involve TNF-A, interleukin 6, interleukin B, that associated with peripheral and central nervous system involvement. Their pathophysiology involved with inflammation and immune responses. In acute phase, there is a release of pro-inflammation, while chronic phase associated with the reduced inflammation, but mediator contribute their osteoporotic changes. While neurogenic inflammation stimulate release of neuropeptide that further worsen the inflammation, and autoimmune component associated with the antibodies. And the pathophysiology part 2 associated with sensitization and ANH dysfunction. So sensitivity increase that enhances the pain signal that leads to the allodynia. And the ANS dysfunction in acute phase, there is sympathetic inhibition that lead to vasodilatation, while chronic phase lead to upregulation of adrenergic receptor that lead to vasoconstriction and that lead to coolness. Their diagnosis criteria, Budapest criteria, as it was already covered. I'm skipping this slide. So basically, it's a clinical diagnosis CRPS. So we have to rule out other differential diagnosis of CRPS. So there are many other differential diagnoses like neuropathic pain syndrome, vascular diseases, inflammation, myofascial pain, psychological problems. There is no specific test for diagnosed to CRPS. We have to rule out other causes of the CRPS like CBC, ESR, C-reactive protein to exclude inflammation, nerve conduction velocity studies to basically differentiate between type 1 and type 2, quantitative sensory testing to basically detect nociplastic and neuropathic subtypes, thermography to basically assess vasomotor disorders, and imaging to demonstrate osteoporotic changes. So there is other imaging, diagnostic imaging, three-phase bone scintigraphy, and this test has high sensitivity, but and their clinical role is that if it is positive, there is high chances of the CRPS. However, negative finding does not exclude the presence of CRPS. Come to the thermography. In thermography, basically, they assess small skin temperature differences and their specificity is 100%. Basically, we come to in analgesia in the CRPS. Basically, CRPS pain type is multi-mechanistic. So there are various types of the pain: nociceptive, ischemic pain, neuropathic pain, nociplastic pain. So pain which have dominant category, we should target of that category. Come to the management. So in management part, there's two parts. There are non-invasive modalities and invasive modalities. So in non-invasive modalities, first we cover the physical therapy, physical and occupational therapy. While in medical management, we just target the inflammation. So first we start with the NSAIDs, steroids, bisphosphonates. While in medical management, we target neuropathic pain. So for which we use neuropathic pain drugs like gabapentin, pregabalin, and ketamine that modulate central sensitization, botulinum toxin if it associated with dystonia, and antioxidants. This one is a proposed algorithm for the management of complex regional pain syndrome, and it was taken from the Lancet. And there is a first line therapy is we have to educate the patient, gentle moving and loading, and by using simple analgesic. And if it is not relieved, in that case, we can go for the intravenous bisphosphonate. And thereafter, we go for the second line therapy that includes psychological therapy, intensive rehabilitation, neuropathic pain medications. And if still pain continues for another 18 to 24 months, in that case, we go for the neuromodulation. So come to the physical or occupational therapy. In that case, main concern about the CRPS is patient fear of the pain. So that can be relieved by using massage, TENS, acupuncture, isometric strengthening exercise, desensitization, mirror therapy. This one is a slide that shows the motor imagery program. So we have to come the basically management part. So first come to the inflammation part, for which we need anti-inflammatory drugs. So there is mainly bisphosphonates. So bisphosphonates basically bone resorption at the site of inflammation in the affected limb contribute to the CRPS. So basically use of bisphosphonates to decrease osteoclastic overactivity that has shown promising effect in pain reducing effect. So there are different regimen of the bisphosphonates: alendronate, pamidronate, neridronate. In them, most commonly we use pamidronic acid at a dose of 60 milligram that diluted in 500 ml of 0.9% normal saline, and that infused at 15 milligram per hour over 4 hours each month for the 3 months. And even Royal College of Physicians guidelines has advised to use bisphosphonate within 4 months of disease duration. However, bisphosphonate is associated with certain side effects like transient hypocalcemia, musculoskeletal pain, renal toxicity, ocular side effects. These are a few studies or RCTs that show the various finding related to the various types of bisphosphonates. Come to the glucocorticoids. So basically, glucocorticoids or steroids are used for the short-term management, and they are mainly target the inflammation. And as per this study, there's evidence to support glucocorticoid treatment in the CRPS. However, ideal administration and route remain still unclear. Initially, we can use the prednisolone in a dose of 30 mg per day for 4 to 6 weeks, and that can be tapered over the next weeks, and it can be continued over the maximum of 12 weeks. Dexamethasone can be used at a dose of 8 mg once daily for the 7 days. And methylprednisolone 1 gram IV for 3 to 5 days. We can use calcitonin in combination with physiotherapy for the patient who have mild or moderate symptoms that inhibit osteoclast activity and promote the release of beta endorphins. And dose is 300 international unit internationally daily for 2 to 4 weeks. If pain or function improve, in that case, we can continue for up to 3 months. We can use the free radical scavengers like dimethyl sulfoxide cream and N-acetylcysteine. DMSO is more efficacious for warm CRPS type 1, and N-acetylcysteine is more effective for CRPS type 2 in a dose of 600 mg thrice daily for 17 weeks. Vitamin C. So there is a study supported the use of vitamin C as an antioxidant in a dose of 500 mg once daily for 45 days post-surgery, especially after TKR, wrist fracture surgery, or hip arthroplasty. Come to the analgesic and adjuvant in the CRPS. So basically, NSAIDs has no significant efficacy has been shown. Gabapentin basically has role in minor effect in reducing pain, but it reduces sensory defect in the lower limbs. In early phases of CRPS, opioid can be used temporarily for the nociceptive pain, which is particularly associated with the inflammation. Ketamine has also appeared to be effective in the reducing pain. Topical ketamine has some role in reducing allodynia. So there is a role of ketamine infusion that acts as NMDA receptor antagonist, and in them we use low dose ketamine infusion over 6 days. Initially, we started the infusion at a rate of 0.05 mg per kg per hour, and dose can be tighter as per the pain relief and the side effects, and the maximum dose can be given up to 1 mg per kg per hour. And in that case, we should monitor LFT before and at the 3rd day of infusion. And there's only a moderate quality evidence in support of ketamine infusion. There's another study that shows the ketamine efficacy in reducing the VAS score. Come to the vasodilator, and the vasodilator basically used for the vasomotor symptoms, and in the most commonly used nifedipine and alpha-adrenergic blockers. In early stage of CRPS, less than 3 month duration, that nifedipine and phenoxybenzamine are effective. However, no RCT available regarding this. We can also use phosphodiesterase 5th inhibitor like tadalafil. In them, basically there's significant decrease in the pain seen, but there is no reduction in the temperature, and RCT is available in support of this. And tadalafil is used in a dose of 20 mg per day for the 12 weeks. This one is the RCT that was in supported for the tadalafil use. But there is only significant reduction in the pain relief, but there is no reduction of the pain part. Come to the muscle relaxant or spasmolytic, and it is used mainly for the motor subtypes. Most commonly used is baclofen. Baclofen is GABA agonist, and it's bind to the presynaptic GABA B receptor. It's a water soluble, so there is no chance of crossing the blood-brain barrier. And it has intolerable side effects like muscle weakness, sedation, and it can be used in a dose of 5 to 30 mg per day. Maximum dose that can be used is 120 mg. And those patients who are not tolerating to the baclofen, in that case, we can use intrathecal baclofen. This one is a study in the support of oral baclofen in the management of spasticity. So adverse effect associated with the oral baclofen is muscle weakness, nausea, paresthesia. So intrathecal baclofen is a viable option in patients who experience particularly this intolerable side effect. So after when non-invasive management fail, in that case, we can come to the basically invasive management, and in them we use sympathetic blocks. Sorry. So sympathetic blocks may provide a significant reduction in the pain by blocking the sympathetic pathway at the of the physiological stage in the CRPS. Basically, their greatest limitation is that they provide short-term relief in the vast majority of the treated patient. But this form of therapy should be used to provide pain relief so that patient can perform physical therapy exercises for functional restoration. And another mode of invasive intervention is spinal cord stimulation. High-level evidence is support its role in improving pain. Another one is dorsal root ganglion stimulation. It is also more effective than conventional spinal cord stimulation, but it allowed more targeted stimulation. Amputation is rare one. It's a last resort for refractory intractable CRPS type 1. So sympathetic block basically used as a diagnostic tool, whether pain is sympathetically mediated pain or sympathetically independent pain. As per this study, both saline and local anesthetic injected of the sympathetic ganglion, and mean duration of pain relief was seen in case of local anesthetic as compared to the saline. There is another sympathetic block outcome, and as per this study, it's a retrospective review, and there is a significant pain relief in 61% patient, and majority endorsed relief pain for the short duration for 1 to 4 weeks. So basically, as per this guideline, Royal College of Physicians suggested that sympathetic blocks are basically used for breaking the pain cycle. So we can use for functional restoration. Come to the neurostimulation, and there's various mode of neurostimulation. So neurostimulation, we can use spinal cord stimulation, dorsal root ganglion stimulation, peripheral nerve stimulation, transcutaneous electrical nerve stimulation, deep brain stimulation. And in neurostimulation, basically we utilize percutaneous or surgically placed lead in the epidural space, implementing electrical dose via an implantable pulse generator. So come to the spinal cord stimulation, it's a minimal invasive neuromodulation, and it's effective for the pain reduction. And their mechanism of action is they activate the beta fiber and dorsal column and modulate the pain signal by activating inhibiting neuron. And their most common side effect in that case is lead migration. Another mode of neuromodulation is dorsal root ganglion modulation. And here you see there is small or more precise lead are placed over the dorsal root ganglion itself. And in this slide, you see that how dorsal root ganglion works, that act as a various way by downstream deactivation of sensitized WDR neurons, modulate the supraspinal brain regions, upstream vasodilatory effect, decrease ectopic firing of the neurons. So there is one study that supported yield dorsal root ganglion stimulation, yield high treatment success rate for the CRPS. So as per this study, there's all are the summary of evidence. We can use intravenous bisphosphonate, low dose intravenous ketamine, sympathetic blocks, and spinal cord stimulation and DRG stimulation have moderate quality of evidence. And there is a, so now come to the pediatric CRPS. So pediatric CRPS 1 and 2 also occur in children. In contrast to the adult, children with CRPS most often have lower limb involvement, and children present with primarily colder affected extremities and less pronounced neurological symptoms. So main conclusion of this study is that CRPS require a multi-modal, individualized and staged approach. Budapest criteria still remain the essential diagnostic tool. Future direction need to further elucidate the underlying pathophysiological pathway, and we need more robust clinical trial for various treatment modalities. Thank you.
Thank you, Dr. Amol. So I'll pass on to our faculty for further questions and discussion about the paper. I think we have one question also. If any word on the management should be tailored as per subtype, like I think Dr. Ayush means chronic or acute, I think, or practical experience of using ketamine.
Okay. First of all, thank you, Dr. Aravind and Dr. Amol. I would say really nice presentations, a big effort. And I must applaud both the speakers for their, both the presenters for their huge efforts. So must congratulate them. Now, is Dr. Aravind also around? Can he switch on the camera?
Yes, ma'am. Yes, ma'am. I'm around.
Right. So we can, maybe come out of the presentation and have the discussion.
You can stop sharing, Dr. Amol.
Okay, ma'am.
So I would like to, open the house for discussion, and then I have penned down few of the queries and questions for discussion, whatever way Dr. Aanchal will say. Aanchal, you want me to start, or I think
Yes,
better
ma'am.
is to take up what
Yeah.
you.
Let's take up the questions. If you can
Yes.
answer the questions, and then we can
Right.
make the points.
So there is one question which came from Dr. Ayush. Any word of management should be, if the management should be tailored as per subtype. So Dr. Ayush, can you just be much more clear about your question? You wanted to know about subtypes in what way? Acute, chronic, sympathetically mediated pain, sympathetically independent pain, warm, cooler. What is that you want to ask? You can
Evening.
switch
Good
on
evening, ma'am.
camera or
Yes.
yeah.
Good evening, ma'am. Ma'am, I meant, should it be tailored as per vasomotor, pseudomotor? Because some articles speak about this. So is it something to practically do as well or not?
Okay, who would like to take this question? Dr. Amol, can you stop sharing the screen, please?
Just a minute.
So Dr. Arvind and Dr. Amol, any one of you want to take, and then or we can proceed further with the answer.
Okay, ma'am.
Right.
Actually, as per my personal experience, ketamine infusion basically used for the refractive management, and it's basically used for the acute state of the CRPS, which are not responding to any mode of the other conservative management. In the we use the low dose ketamine infusion started on the day 1, and some use the cocktail like propofol, ketamine, and midazolam.
Right. No. So I'll just make you stop here. The question, Dr. Ayush, will come to your first question later on, because Dr. Amol has picked up the second answer. So we would have different experience, but the guideline and recommendation, what do the guideline and recommendation say? Whenever we have a refractory CRPS patient who's not responding to the oral medication or the conservative management, we take up the patient for the ketamine. Now the personal experience varies. We would have been using this way Dr. Amol said very clearly, which is very nicely prescribed, that you start with the low dose ketamine, and then you can increase the doses depending on the response. Usually in chronic pain, a combination or a cocktail is not being used. In chronic pain, we use ketamine all alone. Psychedelic effects are usually taken care by the starting it with the lower doses or giving some minimal doses of midazolam before starting the ketamine. My own experience is that you have to keep few things practically noticeable, that if you're using a daily regime, you would ask your patient to be fasting before the ketamine, right? Because of the psychedelic effect as well as the, so you will give that ketamine infusion for around maybe 2 to 3 hours or 4 hours. So your patient will come fasting, then the patient will be taken in the post-op or maybe post 3 hours of infusion, and post infusion the patient would be monitored, might also be fasting because of the psychedelic effect. So the patient remains fasting for some good time of duration during the whole day. So I do not use a daily regime. If I have to choose for ketamine, I would choose either an alternative regime or by the twice a week. These are the reason for logistic reasons also, because we have pain clinic only running 2 days, then we have pain OTs. Agreed, that's not the reason, but recommendations say daily, but you have to keep in mind the practical aspect of this. So your attendant should also be, the caregiver should also be very well versed of it. So generally they get food with the patient. Once we give them clearance that you can take them to the home, they start, they feed them, because otherwise ghar jaake they will reach home another some time, long time. So these are the practical things. Evidence, as said, evidence is still level 3. It is still not more than level 3. It is not even 2B. Right? So this is what is my point, my bit of saying. Anyone wants to add more about this question? Then we can take up the next one.
Ashu sir, do you have any experience of using ketamine in the
No,
CRPS patient?
no.
Okay, I have used
Because in setups like ours, asking daily for coming and getting admission for 10, 12 days, it's a huge cost issues. So in corporate setup, Madam Ghai might have the best
I
experience.
don't admit, sir, Dr. Ashu, I don't admit. I mean, it is again, हमारे patients के पास तो पैसा ही नहीं होता. So what do? They come in the morning, they go back. They come in the morning and they go back. And my experience is also not very huge, but I've used it in
The
nearly.
reason is what you are saying. If we can convince a patient, but we know the evidence are weak. So in a private setup, asking patient to pay so much of amount with level of evidence which is very weak. So probably I will not
Well
use.
taken.
I'll
Yes.
come to the point what we are using, and I'll discuss a very interesting case also. But after these questions, right?
Yeah, even I had two interesting adolescent cases, upper
Yes.
limb, lower limb. But if we'll have time, yeah.
Yes.
Next is, Ayush, your point was if we have subtypes like pseudomotor, motor atrophic, yes, there is going to be an individualized targeted scenario. If you have more of pseudomotor, you would like to use, a sympathetic blockade. Yes, these are targeted, but you have to keep it in mind, all of you, that CRPS patient does not come with one scenario. They come up with a bunch of problems. And the non-pharmacological management, which was emphasized like massage or physiotherapy, they do not even allow you to touch. They come
Touch.
up,
Yes.
yes.
They cry, they shout.
So they come up with
Forget about all this.
allodynia,
Yes.
hyperalgesia. So our main aim is to make them reach to the occupational therapist. Okay. So to keep them to the rehab scenario, we have to do lot of things. So main focus is when we talk about in chronic pain, we talk about not focusing only on pain relief, but on this on functionality. But here in CRPS, as a pain physician, our main focus is give pain relief as much as possible or pain reduction so that they are able to do their some of the physiotherapy. So yes, focused treatment is required. Let's go to another question, which is any recent update on mushrooms? Sorry, I'm not aware of anything like that. Anyone else can comment on this.
Mushroom aflatoxins in CRPS. Maybe something newer thing has come up because it was both the papers which were taken. The speakers have added additional updates as well. It's not only one single paper. They
Yes.
have put additional updates as per the requirement of the topic. So I do not see any mention about that. Probably the person who has written it, can just come up and unmute themselves and they can
Mahi.
where Dr. Mahi, if that person can just say where they have read it or if there's anything. And then commonly used topical agents for CRPS. I think one of the speakers mentioned that DMSO creams and
It is available on Amazon.
Yeah.
It is available.
Yes. Another thing which has come up is a high concentration of capsaicin. 8% capsaicin, but
Is it still available?
It's
The
not available
patch?
in India.
It's not
No,
available in India.
India, it's not available.
India not available.
Low dose, which is available, which is also not very difficult, which is available in Delhi and Gurgaon, but not in Chandigarh.
No, it is not available, ma'am. Even creams are 0.25%. So how can you imagine using 8% capsaicin?
No, even 0.025 is not available.
Not available.
Not individually, ma'am. And that too also is along with the mixture, like other diclofenac.
Yes.
So they will add, and even I tell you, 0.5% is not available. It is always 0.25%. So
okay,
practically it is not available with us at least.
Any word of management should be tell. Okay, fine, that's fine.
I think the person is sharing the ketamine infusion, 4 to 6 hour infusion. No one admits for ketamine infusion. I think everyone is doing daycare these days. Like when I do ketamine infusion for fibromyalgia, I've not done it for CRPS, but for fibromyalgia patients, when I do ketamine infusion, they are just daycare. They come NPO.
Yeah, it has to be daycare. Yes.
Yeah.
One thing which is not mentioned, I do not know whether it is not available in the literature, is lignocaine infusion.
Yes.
Primarily for fibromyalgia, but there is also a role in CRPS as well.
Okay. Yeah, I did not see any of the speakers have
Ma'am,
any word about did they find anything about lignocaine infusion?
ma'am, it was not mentioned in that particular paper. However, Chicago regimen is available for both lidocaine and ketamine infusion.
Okay.
Right.
It is mentioned. You will
Hmm.
find some mention in the literature about lignocaine use.
Available.
Like with ketamine, sometimes you can take it as a personal preference, but again, level of evidence is weak.
Yes, sir.
Whatever we do.
And it is mentioned in the Benzone, ma'am, itself, 6th edition, ma'am.
There is a question from Prasanna, which is a very long question. We will take up another question because Prasanna, your case presentation doesn't fit to me. It does appear to be more of most amputation stump site pain rather than CRPS. We'll take up that because I have used Pinsta, 8% in UK. This is okay. Dr. Preet is there with us?
Yes, thank you.
Good to see you, Preet.
Thank you. I'm sorry it's too late. The
It's
lights
okay.
are off. But I have used Cadenza, 8% capsaicin in the UK, and it did work. It was only licensed for CRPS, for post-surgical pains, for shingles pain and HIV neuropathy. CR patients were pretty miserable after Cadenza, unfortunately. But they had average results 6 to 7 weeks at the most, and that to only 1 in 3 patients, not anymore. So I wouldn't recommend it, and it's not available in most parts of the world, unfortunately.
Okay.
Thank you.
Thank you, Preet. Thanks a ton. So that's really about next one, virtual reality in CRPS. Virtual reality is coming up in a big way as an research modality. However, its role in CRPS is not very well studied. What is very well studied and is also quoted is mirror therapy. Dr. Amol also mentioned. So, if you would, if you imagine the mechanism of action of mirror therapy, don't you think it is more of virtual reality? So, in my opinion, I think if we come up with more evidence, virtual reality might have some of the role, but everything is, that is suppressing the brain activity, preventing or managing at the nociplastic level wind up phenomena. However, keep it in mind that virtual reality has its own side effect. So, in patients with CRPS, what would be the role? I really do not know. It is coming up as a big thing and as a research modality. Anyone else knows about the role of virtual reality in CRPS can comment over it.
Ma'am, in my article, it has been mentioned that in CRPS, always it should be a multimodal, multidisciplinary method. But in all the multidisciplinary methods, other than the pharmacological things, there has never been a standardized protocol which thing should be given, how many days it should be given, which is better. None of these things has been explored, and everything is in a very, very evolving phase. It is just told there are 4 pillars, and this has to be integrated, but how and what and when and all these things are never clear.
So, Dr. Arvind, you are absolutely right in saying that these papers are not mentioning. We as a pain physician has to take up lot of things. And that is where I wanted to take up all the questions first and then discuss a little bit about 1 or 2 cases if the time permits. So, I think we are finishing up with the questions. Now, there is one question of Prasanna. Prasanna, your question seems to be more like what is LSGBRFA? LSGBRFA.
Lumbar sympathetic block.
Number sympathetic ganglion.
Sympathetic.
So, Anchal, you and Dr. Ashu can comment over it.
Yes. So in lower limb, we do lot of lumbar sympathetic RFA, in particularly as I am dealing with cancer patients and pelvic cancer or something which is invading the lumbar plexus. We have done a lot of sympathectomy with very successful results. So it is a very effective method, particularly in type 2, where the lumbar plexus is involved.
No, that is fine. His question was a case report. You are absolutely right. Lumbar sympathetic block has a role in CRPS.
So what is asking?
what he meant was a patient post BK amputation 5 years back has severe pain at the stump site, neuropathic type. He had relief only for 15 days with LSDB RFA. He underwent exploration and excision of neuroma at tibial nerve and peroneal nerve 6 months back. He has more pain now. Could it be CRPS? There is okay, no pseudomotor and skin changes.
Ma'am,
In
dorsal nerve to ganglion ablation.
in my
Which he has
opinion,
missed.
okay, first he is asking about a diagnosis. Sorry, Dr. Ashu. First he is asking about a diagnosis. In my opinion, the diagnosis seems to be more of neuroma, excision, neuropathic pain. It is probably less of CRPS because in CRPS you usually see pseudomotor and skin changes, and it is currently 6 months. As such, neuroma excision can per se cause lot of neuropathic change.
Yes.
Pain.
And any sensory changes, pain also has not been mentioned, like any allodynia, hyperesthesia. So for Budapest criteria, you would at least need 2 out of 4 or 3 motor out of
It
4.
looks like more of a stump pain where dorsal nerve ganglion ablation does wonders. So
Yes.
we treated many patients like this. Always when there is a stump pain, you should first do ERG block, then go for sympathectomy. It should be other way around.
So somebody also mentioned, could it be a diaphragm pain? Yes, it could. Yes,
it's
it
a
could.
yes.
So if I would go on for some discussion, Anchal, can we
Yes,
take
ma'am, please, yeah, ma'am, and then Ashu sir can discuss because these are the real scenarios we would love to
Can
hear.
we take 15-20 minutes? Is it okay?
Yes, ma'am.
Right. So, few questions. This will be, fire questions. Dr. Arvind, QSART. Are you aware of what is QSART? QSART? How do you do that? If you are aware, we will not discuss. This is more of a right now, more of a viva out of your
academic purpose.
So
No, ma'am. I have heard it for first time, so I don't have much practical experience. I have not seen.
Are you doing this at your institute?
No.
So anybody doing this?
I am doing QST. I am doing QST, not all 7 batteries.
Okay.
So QSART is also a very difficult thing to do. It needs training. Our neurologists are doing it for research purpose. But because somebody mentions in the presentation, if you're going for a viva, or this is not examiner scenario, but whatever. So if you're mentioning something, please be aware of that, how we should do it.
Nobody is doing this. This is what I feel.
I don't think anyone has experience of QSART. No. So I have been using QST for research purpose only. But that is also our homemade, Jugaad wala QST. We have Bonfrey, we had algometer. We have now got a slightly refined algometer, and we are in the process of patenting our own QST, which is we are making 4 batteries: Bonfrey, algometer, the temperature cold and warm temperature. So still the industry funding is not there. So, but we have got the design patent done. So what German people are making in 20 lakhs, we probably can make it in 2 lakhs.
Oh, that's great.
Okay, so that is still not 7 batteries. We are making 4 batteries. About biomarkers, I just one comment. These biomarkers are very non-specific. Do not have any specific CRPS biomarker, except for one thing. CGRP has been very well evaluated for CRPS, and this is measurable in India and all the labs. So CGRP focus should be more, right? About functional MRI, in my understanding, functional MRI is a brain MRI, which tells us about functionality. When I do not know the role here, if functional MRI is for the bones or the part affected.
It's a brain for hot and cold spots, and I think that is what functional MRI is. Dr. Anchal, what do you say?
Yes, sir.
Ma'am, in functional MRI, it has been mentioned that the psychological component is also a significant factor which is involved in the CRPS, and especially with the chronic changes, the psychological things come into play. So
that would also be very non-specific laboratory testing. So it won't give you anything much. Functional MRI, even you and me presenting currently can have very various functional MRI picture. So it is not very specific. So we should not be using it. Maybe those articles were mentioning, but we can rethink over, in a critically how should we analyze. Another thing is bone scan you mentioned, and Dr. Amol mentioned something very good, which we are doing currently in our practice also, three-phase scintigraphy.
Yes.
Yes, we are doing three-phase scintigraphy, and
So
this is becoming much more reliable and specific.
So we look for the phase 3 uptake, and if this is positive, it is very specific for CRPS. So all chronic patients with CRPS must undergo triple phasic bone scan and late reuptake. I'm using very specific word. The late reuptake is diagnostic of CRPS, and all these patients behave very well to bisphosphonates. Then you give aldronate 4 milligram IV monthly for 3 months, and you see wonders.
Right.
So this is what practically we are using in our patients, not these QSTs and all this.
In our setup, nuclear medicine people do the
Yes,
scintigraphy
nuclear medicine paper will do.
nuclear medicine people do the scintigraphy for us, and depending on the scintigraphy result, as you said, Dr. Ashu said, we use bisphosphonate or we do not use bisphosphonate.
Yes.
We make diagnosis, warm phase.
Reuptake. I think that is one of the non-invasive modality which should be tried, I think, before going for invasive or ketamine or something.
Right. Also, with this, many modalities were enumerated by Aravind as well as Amol. However, we could not speak, we do not have also time, we could not speak about the level of evidence. Amol presented in last one slide, which was
can you represent that slide, the level of evidence?
Yes, that is very important, because we could not talk about NNT or NNH. However, finding NNT or NNH of any drug for CRPS is extremely difficult. But at least Amol presented a good slide of moderate evidence, minimal evidence, or a limited evidence. Amol, that was very good slide.
Thank you, ma'am.
So we can, if आप वो share करके हमें दिखा सकते हैं, that will tell us.
You can elaborate slightly on that slide. Dr. Anchal, allow him to share, just to strengthen our knowledge.
About
Just a minute.
Role of steroid. While he was planning to share role of steroid, we will talk about that. DMSO cream, as Dr. Ashu said, it is available in India.
It is available.
Yes.
उन पे freely मिलती है.
Right.
अपने एक दो पे use भी करी है.
About CRPS is one of the known indication in NICE guideline and USA, UK, Australia for spinal cord stimulator. अब हमारे पास स्पाइनल कॉर्ड स्टिमुलेटर नहीं है, और डीआरजी न्यूरोमॉड भी बहुत अच्छी चीजें हैं. सो व्हाट वी कैन डू, हमारे सेटअप में हम क्या कर सकते हैं?
हमारे सेटअप में मैडम हम तो डीआरजी एब्लेशन करते हैं.
राइट, हम डीआरजी पीआरएफ कर सकते हैं.
पीआरएफ करते हैं.
हम ना एब्लेशन नहीं, मतलब हम क्या करते हैं, अब हमने क्या करना शुरू किया, डीआरजी स्टिमुलेशन फॉर 15 मिनट्स. तो लॉन्ग ड्यूरेशन, फिर उनको बुला लेते हैं महीने में एक बार, 2 महीने में. हाँ, इसको एनलार्ज करो बच्चे, ये एक अच्छी है. दिस इज विच ईयर?
हाँ, ये वाली स्लाइड थोड़ा इलेबोरेट करो.
2023 recommendation.
Recommendation in 2023
का है moderate evidence.
So
moderate evidence, basically, as per our this review article, they have the moderate evidence in favor of only spinal cord stimulation and DRG stimulation, sir.
Right.
Okay.
As per this review, as per this article, evidence-based review, in that case, intravenous bisphosphonates, even sympathetic block with local anesthetic have moderate evidence, while in 2023 they have not so much significant, ma'am.
But ये हमारे लिए बहुत important है that you see somebody has collected the evidence for us and published in 2023 recommendation. So IV bisphosphonate still stays as moderate, low dose intravenous ketamine still stays as moderate, sympathetic block with local anesthetic only stays at moderate against. Okay, so sympathetic block with local anesthetic is gone, moderate against.
That this is only for short duration, basically break the pain cycle.
Yes, so moderate against.
Generally repeat the sympathetic blocks and just ask the patient for the functional restoration.
नहीं, but आपका moderate against means it is going moderate against the use of this blocks.
Yes, ma'am.
वो क्यों हो गया? कुछ उनका evidence, I mean, was it been used more in sympathetically independent pain? I don't know.
It is written below. It is written below. Sympathetic blocks with local anesthetic have a moderate recommendation against the use of CRPS for long term. However, moderate in favor for the identification of sympathetic mediated pain. Not
तो
for the
एक बार
treatment.
आइडेंटिफाई हो गया तो क्या करेंगे?
RFA.
अच्छा, local anesthetic alone.
Yes,
Okay,
yes. For the treatment purpose. They have mentioned these lines below. If you can read.
Okay, fine. Amputation only for the functional improvement. Fine. So, local anesthetic alone is got moderate against ki long term में तो effect करेगा ही नहीं.
Right. It is only for diagnosis. They say use it for diagnosing sympathetic mediated pain.
Right. So these are very important recommendation, Dr. Amol. And you are like sitting on a bombshell here, and you just skipped this slide. This is very important for us.
Yeah, this is one of the most important slides that we want to listen and discuss.
Okay, so right now spinal cord stimulator has moderate evidence. DRG stimulation has also moderate evidence. Fine. So now what has happened that in our setup, what we can do if the logistic permits and the finances permits, we can do some frequent monthly DRG PRF, prolonged PRF, maybe 5 cycles of 3.
Ma'am, we do 10 minutes PRF.
Okay, so 12 to 15 minutes.
10 minutes.
Right. So we have very recent RAPM article which says 12 to 15 minutes has been also evaluated, and they go in favor of more so in, they studied 3 groups, 4 minutes, 6 minutes, and 12 minutes. I'm forgetting.
But we are doing for long time now, maybe 7-10 years, 10 minutes.
Right. So 10 to 12 minutes is also recommended. Okay. Yeah. So ये है, and अब हम आते हैं एक real case. These were my questions. Smoking, DRP, fine. हमें NNT usually ढूंढने ले चाहिए, but NNT मिलेंगे नहीं दवाइयों के. Now let's come to one real case scenario which Dr. Aravind was saying, that we talk about multimodal management, but we do not quantify or say how to do it. We have a 18-year-old girl, 16-year-old girl who has been a basketball player. While playing the basketball, she injured her wrist, and she developed pain which was lasting for 6 months. She went to a private practitioner, somewhere a local practitioner, and he injected steroid here, and that led to excessive increase in the pain. And she came to us after 1.5 years visiting many doctors, and she had again all the pseudomotor, allodynia. She would come up with a pillow kept under the hair. So she had pseudomotor, she had vasomotor, she had allodynia, she had not been using these, she had trophic changes, she had these big nails swollen. So all the proven signs of CRPS. She had been to multiple doctors. She had been taking pregabalin, gabapentin, duloxetine, amitriptyline. She would not allow people to touch. She was not being able to do any physiotherapy. क्या करेंगे? आपके पास she has come to you after 2 years.
डॉक्टर आंचल बताओ क्या करोगे?
We will check if the patient has sympathetic mediated pain or not. We can plan for sympathetic block first and check, because that is something we can plan of giving long-term relief with if she has.
मैं आपको यहाँ रोकूंगी. तो सबसे पहले मैं क्या करूंगी, ये पेशेंट वो है जो 10th के बोर्ड लिखने वाली थी, 9th में शी वाज टॉपर. अब उसने 10th के बोर्ड नहीं लिख पाई, और वो 2 साल से ऐसे पिल्लो लेके घूम रही है. मैं अभी कोई इंजेक्शन नहीं दूंगी. अभी सबसे पहले उसकी साइकोलॉजिकल इवैल्यूएशन करेंगे. She cried for 2 hours. She cried for first day 2 hours that I cannot do anything. She's beautiful looking girl who's been like not able to take bath. So Dr. Aravind, role of psychological assessment,
evaluation,
है ना. So पहले तो उसको एक्चुअली स्पीकिंग हमें पहले दिन उसको 2 घंटे लगे, क्योंकि वो अपने पेरेंट्स के सामने नहीं कुछ बोल रही. शी थॉट कि मेरे पेरेंट्स मेरी वजह से रो रहे हैं. इतना उसके ऊपर बर्डन था ऑफ साइकोलॉजिकल बर्डन. वो खुद शी कुड नॉट राइट हर 10th. शी हैड टू ड्रॉप 1 year. शी वॉज क्राइंग फॉर द फैक्ट दैट आई वॉज टॉपर. मेरी जिंदगी बर्बाद हो गई है. आई कैन नॉट राइट माई बोर्ड एग्जाम. तो हमने क्या करा, वी डेवलप्ड एस्टैब्लिश्ड अ रेपो involved a pediatric psychologist. We have to get also lot of psychological training ourselves. ठीक है, सो हमने उसके साथ वो रेपो बिल्टअप करी. वो लड़की हमें हाथ नहीं लगाने दे रही थी. It took us 1 to 2 weeks, and I take pride. It took us only 1 week to reach to कि हम स्टीलेट लगा दें आपको. बच्चा, उसने 16 साल की लड़की थी, स्टीलेट लगवाया. स्टीलेट लगा के मिनिमल इफेक्ट आया, कोई मेजर नहीं. इतनी देर में मैंने अपने इंटरनेशनल ग्रुप्स में, नेशनल ग्रुप में, डॉक्टर आशु नोज, ये वाली पेशेंट हमने डाली थी. सबने बोला, किसी ने बोला विटामिन सी दे दो, हमने दे दिया. किसी ने बोला, डॉक्टर अनुज भाटिया ने बोला अभी भी रोल है ग्लूकोकॉर्टिकॉइड का, जबकि एविडेंस कहता है कि आफ्टर 6 मंथ्स या आफ्टर एक्यूट फेज के बाद ग्लूकोकॉर्टिकॉइड का कोई रोल नहीं है. हमने उसे हाई डोज ग्लूकोकॉर्टिकॉइड दिए. एवरीथिंग टुगेदर वी वर्कड. एक स्टीलेट लगाया, बट इट टुक अस रियली गुड मंथ्स बिफोर शी कुड इवन डू सम मूवमेंट. स्टीलेट के बाद उसको पेन रिलीफ हुआ 15 डेज के लिए. एक डेडिकेटेड फिजियोथेरेपिस्ट उसके घर में लगाया, बिकॉज या तो वो कभी मूवमेंट कर ही नहीं रही थी. सो डेडिकेटेड फिजियोथेरेपिस्ट उसके घर में आए, जिनसे हम फोन पे बात कर रहे थे. वी सेंट हर टू मिरर थेरेपिस्ट, जो हमारी एक रिहैब टीम है, वो मिरर थेरेपी करती है. ये सब इकट्ठे किया, एक एक करके नहीं करा, बिकॉज हमें 2 months लगे टू रीच टू वन स्टेज where she could start moving little bit of her metaphalangeal joints, and that was the time we achieved something. After 2 months we told her, now slowly you will have to go to. She did not allow us a second distillate. That means we were giving her graded doses of gabapentin changed to duloxetine, which we tried, which we all of us do. Okay, so whatever suited her. Finally, it was not medication, it was bit of steroid which worked, more of psychological involvement, more of occupational therapist, more of some pain relief from our side in any form of ultraset or. So finally 2 महीने के बाद she started moving, and then slowly again another 4 months she reached to a stage where she moved. और जैसे ही उसने अपने हाथ मूव करने शुरू करे, उसके सूडोमोटर और वेजोमोटर सिम्टम्स कम होने लग गए. राइट, एंड देन 1 साल में हम उस स्टेज पे आए जब वो अपने नाखून काट सकी, और जब वो अपना एक साथ में एक पर्सन को लेकर एग्जाम लिख सकी, बिकॉज शी बिकेम साइकोलॉजिकली सो स्ट्रांग कि हाँ अब मैं लिख सकती हूँ. शी रेड, हमसे उसने परमिशन लेके एक राइटर लिया, एंड देन टुडे इट हैज बीन 3 years. शी डज कम अप विथ रिकरेंसेस, बिकॉज वो कभी गिर जाती है गलती से तो हाथ लग जाता है, बट शी इज बीन नाउ मोबाइल. She does not come with pillow. Her hand is reduced, no edema. ये कट चुके हैं, फिर भी उसको फियर अवॉइडेंस है. अभी रेंज ऑफ मूवमेंट पूरी नहीं आई है, बट काफी आ गई है. ये हमें 3 साल के बाद का रिजल्ट है. So this is how we.
ठीक बात. बच्चों में तो it's difficult.
Right.
I am also struggling with a 16-17 year kid with a lower limb foot CRPS. Every time his father will come, huge psychological issue, 12th के एग्जाम नहीं दूंगा, ये नहीं करूंगा. Every time father comes and asks me for वो इंटरनेट पे पढ़ के कि जी आप ही कर सकते हो lumbar sympathectomy block, I always refuse because of the psychological issue. Young kids very difficult to intervention and get results. So still in my OPD psychological जो आप कह रहे हो और कुछ medicine we are managing with that. I have refused for giving this kind of block.
जैसा आपने बोला डॉक्टर आशु, मेरे पास एक 14 साल का लड़का अभी आ रहा है, चल रहा है अभी. वो आया था 1.5 साल पहले. उसका नाउ सेकंड केस. दिस इज अ लोअर लिम्ब सीआरपीएस. इस बच्चे को जब वो 12 साल का था तब उसको फ्रैक्चर हुआ फुट का. ही गॉट ऑपरेटेड. ही वाज नॉट एडवाइज्ड अ गुड. उसी टाइम उसने मूवमेंट्स नहीं करी जो हम यूजुअली आजकल की प्रैक्टिस में करते हैं. एंकल फ्रैक्चर, अर्ली मूवमेंट, अर्लीस्ट मोस्ट मूवमेंट. ठीक है, आई फ्रैक्चर्ड माई फिबुला, आई एम मूविंग, इट इज नॉट इवन 5 weeks. सो वो हुआ, वो स्टिफनेस हुई. He came to us with black coloration because he did not allodynia, pseudomotor, जो आप imagine कर सकते हो. फोटोज हैं, I can share with permission. Okay, now he is coming on a wheelchair. अब वो 14 साल का लड़का है. I couldn't think of putting up lumbar sympathetic block. So what did I do? There is something unique we did. We gave him, उसने मैं तो स्पाइन पे भी नहीं लगा पा रही थी, हमारा सियाम भी काम नहीं कर रहा था. अल्ट्रासाउंड से मुझे सिंपैथेटिक ब्लॉक देने का नहीं लग रहा था. सो वी गेव हिम ultrasound guided tibial block.
Okay.
It did work.
I also did the ultrasound guided this tibial, common perineal and tibial, because the patient, one of the girl, she was 22-year-old, and it did give her 30 to 40% of relief. She was happy with that.
Yes.
So that is also another option. Peripheral nerve block. We have not seen
Peripheral
it,
nerve.
but in
Peripheral.
the practical,
More so in the lower limb.
more so in the lower limb. Yes, yes.
So pop sciatic दिया था, not even
Pop sciatic. That's what I was saying. The combined tibial and common peroneal, pop sciatic.
पहला पॉप sciatic मैंने उसको दिया लोकल एनेस्थेटिक और स्टीरॉइड से. ओके, उसको जो 2 साल में किसी चीज से रिलीफ नहीं मिला, 15 दिन के लिए ही वाज कंप्लीटली पेन रिलीफ. ही स्टार्टेड, कालका से आता है, फिजियोथेरेपी शुरू करी. वो फिजियोथेरेपिस्ट ने एक रेंज ऑफ मूवमेंट सडनली दे दी 15वें दिन, और उसको दोबारा दर्द शुरू हो गया. सो ही केम बैक अगेन आफ्टर 2 months. सो वी डिड आरएफए, ओके, पीआरएफ. We did PRF. And after PRF, he had a good relief, reasonably good. I would not say, 40% relief. Because इनको तो 40% में मिलता है ना डॉक्टर अरविंद और अमोल, तो ये अपनी फिजियोथेरेपी शुरू कर देते हैं, है ना. उनके लिए वो भी बहुत बड़ी बात है. सो सेकंड हमने PRF किया, 50% रिलीफ था. सो ही स्टार्टेड. नाउ दिस टाइम वी डिड द सेम थिंग एज आई डिड विद दैट गर्ल. मैंने फिजियोथेरेपिस्ट के साथ फोन पे रखा, इसको अगेन एक चाइल्ड साइकोलॉजिस्ट के साथ अटैच किया. मैं बहुत लकी हूं कि हमारे पास एक साइकोलॉजिस्ट रिसर्च ऑफिसर थी, तो हमारे पास एक डीएसटी का चल रहा है, मेरे पास एक साइकोलॉजिस्ट है, एक बायोटेक्नोलॉजिस्ट है, और एक पेन फिजिशियन असिस्टेंट है. तो ये सब मिलकर उसके साथ लगे हुए हैं, उसकी साइकोलॉजिकली करते हैं. अब वो खुश होके आता है. पूरा उसकी मूवमेंट अभी भी नहीं आई, पर वो व्हीलचेयर से उठ गया है. वो एक व्हीलचेयर स्टिक लेके आता है, बट वो उतने में भी खुश है. पेरेंट्स उसके उतने में भी अभी खुश हैं. वी आर एमिंग मोर. ही इज कमिंग टू अस फॉर लास्ट